vaccine was delivered outside of the traditional cold chain, so using a controlled temperature chain, and that was for the Manafavac campaign in November. And so this afternoon's panel is going to be discussing a little bit further the controlled temperature chain, which we call CTC. And the purpose of this panel really is to just provide more insights on CTC and share different views and perspectives on this important innovation, and also to share especially the varied contributions of different partners and partner institutions. And lastly, also, and quite importantly, to solicit your input and your ideas on how to move forward the CTC agenda. So I'd like to start by introducing our panel. So we have Olga Popova, who's going to be offering the vaccine manufacturer perspective, and she's representing the International Federation of Pharmaceutical Manufacturers and Associations, and she's also the Vice President of Global Vaccine Policy and Partnerships at Janssen. And sitting next to her is Franzel, who's going to be offering the donor and vaccine purchaser perspective. And she works at Gavi, where she's a senior specialist on policy and market shaping. And then we have Florence Fermon, who's going to be offering the NGO perspective, and she's representing MSF, where she's the head of the vaccine working group, or vaccination working group. And then you know Dadja Landoh from this morning, and he's going to be offering the country perspective, and he is here on behalf of WHO, the country office in Togo, where he's the medical officer and EPI focal point. And at the end, there's my colleague Patrick Lydon, who's going to be offering the WHO economic perspective, and he's a technical officer and health economist in the EPI team at WHO headquarters. And then I should also introduce myself. I'm Anna-Lea Kahn. I also work in the EPI team at WHO headquarters, and I'm also the focal point for CTC. So I'd like to start by giving you just a quick overview of the controlled temperature chain, and then I'll pass the floor on to our panelists. And so I think one of the most important things really to start with is simply the definition of CTC, and this is something, you know,
Thank you very much for this invitation. And in fact, I do have some historic memory on this subject because I was representing the IFPMA and vaccine industry on the Optimize project when it started dealing with this in, I think, about 2008. It was still called OCC, out of cold chains. I think the CTC came a little bit later when it was better qualified as a concept. And in these years, I've seen a number of debates going on with respect to which vaccines should be done within CTC space, whether it's all API, whether we're going at selected products or target populations like campaigns or special groups. We have seen policy and regulatory considerations being put forward, and I must say that there's been quite extensive consultation with manufacturers over the years and an intense dialogue. We had to remind the community that some antigens are not heat stable, so sometimes you just cannot do this. But when it's possible, there certainly can be ways to look into this subject. It's also the question, of course, as we've seen, the adaptation of existing vaccines to the CTC. Some of the vaccines are inherently heat stable, so you can just do some extra testing to be able to change the license. So we have seen WHO moving forward with regulatory guidelines, and actually I think it's this week that the public consultation has been opened for the adapted and acceptable protocols for the CTC testing, so that was very welcome from our side. Finally, we are also living in the time of the inherent tension between improvement in the products and very high vaccine price pressure. Of course, Gavi market shaping is playing its role, and there is certain incentives in the market that we see today for choosing the less expensive presentation. So everything that a manufacturer would do to improve that would come at a cost would be living through this tension. So this is something we will be needing to look at in the future. And education should be provided appropriately for the countries to be able to choose what they would want to use. We have seen the Gates Foundation really moving forward, and some years ago there was a round table with the pharma CEOs where there was an effort put forward to create some incentives to fund the development of the heat-stable vaccines, but also to revise procurement mechanisms so that countries can select products that best meet their needs. Of course, then we all know the MenAfriVac success story, and I was very happy to see the progress of it in Africa. And then we also see some contradictory messages. For example, last year the Gates Foundation again has issued the analysis suggesting that if there are only 1 or 2 vaccines that are going to be licensed in CTC, the overall savings for countries will be less than 1%. So we need, and at the same time, Gavi is now very strongly launching their investment in the cold chain equipment and supply chain. So I think we need to get a bit clearer guidance about the direction that is going to be taken, what is really that is needed from our side and for which vaccines. Just to give you some example about our own thinking in my company when we were looking at the hepatitis B vaccine. And the reason for that was, I think that was one of the first vaccines that WHO has looked at, in particular because of the need to administer the birth dose to children born at home. So the desire was to make sure that the vaccinators can actually carry the vaccine in controlled temperature chain to the home, to the mothers that have been given birth at home, because the vaccine has to be administered within the first 24 hours. So we as a company have 2 presentations for hepatitis B vaccine. It's a single dose and a multi-dose presentation. And of course, it's a very cheap vaccine today. So to make anything that would require clinical studies or testing that would require extra funding from the company, you need to see to which extent you can offset this by being able to actually have your business case and being able to have this vaccine used and welcomed by the market. So we, of course, had been thinking that for the use of the birth, for the birth vaccination, in particularly in cases where the vaccinators have to go home, it would make more sense to have a single-dose presentation, potentially the compact prefilled outlet-disabled device that we have actually now developed for pentavalent vaccine. But then at the same time, whether that will be economically feasible or not. Another question was thimerosal. You know that in the industrialized countries there are no thimerosal containing vaccines used anymore. And we've seen in some countries there were strong recommendations that birth dose for vaccines should be also without using thimerosal. So the single-dose vaccine has thimerosal, the multi-dose doesn't have thimerosal, sorry, and then the multi-dose vaccine does have the preservative. So the question was, which vaccine should we choose for the CTC licensure? Then again, the question about the clinical trial, what would it take to support the change of the SPC? What should be, from the more technical perspectives, the tests that we will need to make, and what would be the indicators that we would be needing to use, apart from the VVM? What about the VVM? What about other indicators? Would we be able to go through WHO prequalification faster? What about the off-label use of other hepatitis B vaccine? Because we know that today, in many countries trying to solve this issue, they're actually using the hepatitis B vaccines out of cold chain, in the off-label fashion. And finally, who is going to be paying for this vaccine? We know that in the early years, Gavi was funding the hepatitis B vaccine, but now because the pentavalent vaccines have taken over, the hepatitis B should be funded by the countries themselves. So then the question that we always grapple with is, what is the reliable demand? I mean, if the vaccine is going to be available, will it actually going to be used? So I think this is just natural questions that all the manufacturers ask themselves when they embark on the development like such. So then going back to more industry perspective, where do we stand today? I think we have some good opportunities, and subject to scientific feasibility, we can make better vaccines. I think this is the first, and you have seen some examples already, so this is possible. We know that several research-based manufacturers are already investing in that. We have seen the PCV13 being licensed pre-qualified, and there is work ongoing on other products such as HPV, polio, rota. And the tests are being done in order to relicense these vaccines in CTC. Of course, we need to look into the longer term. Do we want to use this formula for the vaccines in development that are going to be used in resource poor settings? Here we also need to look at the role of partners. If these vaccines are only going to be used in the developing countries, can we partner with some of the other organizations to work on this together? There is a genuine desire to address the resource-limited settings in the industry, but there's also a need to have a positive business case. You cannot just develop something because there might be a need and somebody will have to pay for it in the end. I think we just need to define what will be the way of funding this product, the better product, and who is going to be prepared to put the money on the table. We haven't seen yet any incentives in the procurement system to choose the presentations that can be different or better. So this is something I think that the work still needs to be done. Hopefully we can stimulate that for the future. And so we haven't seen for the procurement mechanisms an extra value being built into the system. So this is still something that needs to be done. At the same time, we need to have strong signals on the recommendations for use and the consistency for guidance. Because if there are years that we are sort of called to develop the vaccines in CTC, and then there is also a very strong investment in the cold chain equipment, then please let us know where exactly do you want us to concentrate our efforts. Because maybe, we can do this, but then it may not be needed. So I think this is an important point to consider. And finally, we very much welcome the long-awaited WHO regulatory guidelines. It took a while, but I think now it's becoming clearer what we need to do in order to license the products. So we do still have some concerns. I think one of them is our responsibility ultimately that the vaccines that are administered are safe and potent. I've been very reassured by the presentation from Togo this morning showing that the adverse reaction profile from the CTC vaccine was very favorable. We need to have clearer label guidelines. What if we have one product being licensed in industrials and developing countries? How do we juggle between these two labels, one sort of the regular one and one the CTC label? What is also the place of the CTC alongside temperature excursion studies, because they are now requested by a number of regulatory authorities? And what is the life cycle of the temperature excursion allowance? There are different scenarios where the vaccine can go out of cold chain, so they all need to be tested. So we need to have clarity on the protocols there. Also, the VVM is not going to really help in this case, and we need to look at different temperature monitors. And finally, we need to really see how we want to incorporate CTC in early development. We need to have a viable market, we need to have positive business cases, and we need to have incentives to invest. And finally, when you embark on something that is not very well known in the past, especially if you have to add special components to your vaccine to make it more heat stable, you always risk delay to the market or even a high probability of failure. So doing something that would be different takes some courage and also some, let's say, we would need to have some strong case to make sure that we're going in this direction. Finally, I just want to conclude with the report of the Decade of Vaccines, Global Vaccine Action Plan from last year, saying that really controlled temperature can be cost-saving, and the manufacturers are acknowledging this. However, what we're also seeing is that countries are not yet jumping on the idea of CTC licensed vaccines, in particular concerning about causing confusion about, for the vaccination staff who have been trained for years to use the cold chain equipment properly. Again, the presentation from Togo was very interesting this morning from that perspective, because they had a polio campaign afterwards, and it doesn't seem that there has been a difficulty there. So maybe when we see the report next year, it will be more concrete and more reassuring on the use on CTC. So finally, I think the GVAP report said it for us. we will continue to have vaccines licensed to CTC if the countries want to use them. So I think that's our whole perspective. Thank you.
Okay, thank you very much. So we will wait until the very end for questions. We'll let each panelist present their perspective first, and I think it's going to be very useful to have the manufacturer perspective and a lot of the questions that were raised by Olga, followed by some insights from a donor and vaccine manufacturer, Gavi. So we look forward to hearing.
Purchaser, we're
Sorry,
not manufacturing.
Vaccine purchaser, yes, of course. Thank you.
Good. Thank you, Anna-Lea. I thought it would be useful to familiarize you with our approach to addressing, I think, what Olga was alluding to, which is sometimes a tension between price, supply and demand dynamics, and also the appropriateness of the vaccines themselves with respect to the Gavi countries. So to begin, I wanted to introduce you to the Gabby Strategy. This is our formal mandate, what we are asked to do by our board that governs the Gavi Alliance. And what I'd like to just highlight quickly is you'll see across the principles a lot of relevant words. I think innovation's there, country-led, globally engaged. I think these are really important things that we keep in mind as we consider new things like CTC. And then the second thing that I wanted to highlight on this slide was under the strategic goal number 4, where you look at the 3 bullets under shape markets for vaccines and other immunization products. And I'll go into this in more depth in a following slide, but that last bullet is, I think, particularly where we want to focus this conversation is how are we incentivizing the development of suitable and quality products? So just to remind you the programs that Gavi currently has, and where we see CTC, the CTC approach as having particular value or relevance, we really focus on these 2 middle areas where vaccines are delivered either by campaign or they're provided to a stockpile for kind of outbreak response, mass response, in some kind of a special immunization activity. And then I would put kind of an orange box around the routine because I think the community generally feels that the application of CTC is somehow more limited or a more limited potential in this space. I would make one qualifying statement around the delivery of HPV where because of the setting of the administration of HPV vaccines, it is, in some senses, a campaign because it's not done at a health facility in many instances, it's done at a school. So alleviating the need for all of the cold packs and the like would be very interesting, I think, to also reduce the cost of delivery associated with delivering the HPV vaccine. So coming back to our Sg4 goals, we have to inform the delivery and the move towards the achievement of strategic goal 4 to shape vaccine markets, a supply and procurement strategy that describes the following objectives. And this is where that tension, I think, really comes out, is what are the trade-offs that we're willing to make? Are we willing to pay a premium for more appropriate products? How much of a premium? What if it's at the cost of disrupting the balance of supply and demand? So all of these things have to be taken into consideration. And that's why we portray it visually as a scale, because you want to keep these things in balance and figure out what the right mix is. And then underpinning all of that is the information, the market analyses, the communication between we, the Secretariat, our partners, including industry, including technical agencies like WHO and UNICEF. And so our approach to figuring this out and getting that balance correct is in the vaccine roadmaps. And what we try to do through the roadmaps is begin with a market analysis where we figure out what we know about a given market, and this is antigen by antigen. So for example, we have a specific meningitis A roadmap. And so we look at the broad landscape and we try to understand across those 3 objectives, the balance of supply and demand, the cost to Gavi and the countries, and the appropriateness of the products, what should be the relative priority? And then we set outcomes for ourselves, and sometimes it's an outcome that requires activities to be initiated by the Secretariat. Sometimes it's an activity, here I'm talking about the action plan on the right-hand side there, that is the responsibility of the foundation or the responsibility of WHO. So it really just depends on the nature of what we're talking about in the action plan. But this is how we define what our engagement in a particular market should be. And where CTC makes sense, we want to be able to prioritize that. And so the example that I have here is around cholera. And this is just a snapshot of that roadmap in practice. So we have the market landscape, as I mentioned. That informs our ambition, and the ambition enables our target outcomes. And so under target outcomes, that second bullet is around improved presentations. And this here, I mean, the detail's not on the slide per se, but this is where things like CTC come to the forefront, where we know that because of the way cholera is delivered, being able to take that vaccine out of the cold chain represents a real innovation that has real value to countries. So this is just a bit of a lens into how we consider these different objectives and where there may be trade-offs, how we evaluate those trade-offs. And so in conclusion, for my remarks on CTC, I just wanted to give you a broader lens into where we are today and potentially where we could be in the future. So as Anna-Lea mentioned in her remarks, you know, the first one out of the starting gate was the MenA vaccine. We've just recently had another product licensed for CTC application, and we're also anticipating in the near future a third vaccine to also be licensed for the CTC approach. I think the question from here is, how do we start to continue to engage where it makes sense on the other vaccines that have real value for CTC, and use that to inform the roadmaps, and then start to engage with our partners, again, partners including industry, including technical agencies, to figure out how we can move towards achieving the expanded application of CTC. Thank you.
Thank you. That was very valuable insights, and I'm going to now invite Florence to take the floor, who will give you the user perspective on behalf of MSF.
First of all, I want to thank the organizer to invite MSF to share our expectation on controlled temperature chain. Just to give you a summary of what is doing MSF and why we are really concerned by this new possibility. MSF is working in, 2 years ago, we were working in around 66 countries, and over the 387 projects, there was 55% implemented in unstable situation. MSF established a vaccination policy in 2007. The main objectives are to vaccinate with more antigens, to vaccinate the most susceptible, including the possibility of extension of age according to needs to catch up children. Also, we wanted to implement alternative strategies to decrease the missed opportunities. And finally, we wanted to address vaccination in specific groups, such as HIV and malnourished children. MSF decided to give a special focus to 4 countries a few years ago. It is South Sudan, Chad, and DRC. Also, with the availability of new vaccines and on top of measles in emergency, MSF support the extension of vaccination package in those situations according to risk assessment as per WHO recommendation. Main vaccination activity last year covered 2 areas: emergency responses linked to outbreaks and humanitarian emergencies, and support to routine vaccination. Around 25 measles outbreak responses vaccination were supported with over 1 million doses delivered in countries such as CAR, South Sudan, and DRC. MSF support and push the extension of the vaccination package in emergency situation, and last year we proposed and have implemented several mono or multi-antigen campaigns in those situations. More than 850,000 doses were administered in total. Support to routine vaccination is targeted on countries affected by social and political crisis and on vulnerable groups. The main challenges faced are for vaccination campaigns conducted sometimes in very remote areas and or in crisis setting where the rapidity could increase the impact of vaccination. In remote area, it is always the same population that remains non-vaccinated, as ensuring access with cold chain requires a strong support. The supply chain is more and more complex, with bulky vaccine, with more vaccine, with various thermosensibility, and so on. And finally, the cost to put in place campaigns are also escalating, linked partly to the cold chain requirements. The implementation of the cold chain and the logistics are difficult, especially at the last stage of the distribution. This has been a real challenge last year to implement oral cholera vaccine campaign in Ethiopia refugees camp, to ensure the storage and transport of 350,000 doses and 6,000 liters of vaccine during emergency. CTC could be a huge advantage for MSF emergency and other operations that will reduce the logistic workload and cold chain burden in terms of resources, human resources, and equipment. CTC make easier and faster the implementation of vaccination activities. This benefit will be even more important at the very beginning of emergencies. CTC can help reducing the risk of freezing vaccines, which happen generally during the transport. Consequently, CTC will also reduce the cost to implement vaccination campaigns. It will help also getting populations that are very difficult to reach. It's important to keep in mind these are populations that are repeatedly missed in vaccination activities. A large number of challenges are expected, as for many major change in practices. At manufacturer level, we just have an overview, and the commitment of manufacturer is essential to share its stability data and support that. The review of the pre-qualification of candidate vaccine requires clear guidance for stability evaluation. Also, the availability of a pre-qualified peak temperature indicator is essential to ensure the adherence of operating procedures. At operational level, CTC will not be relevant for every antigen, so it will not apply to some multi-antigen campaigns. Communication and advocacy are key to get country collaboration and ownership. Change of practices may lead to resistances and contradictory messages. Implementation must be closely supported. Good training and supervision will optimize practices and good understanding. CTC approach must be documented and followed rigorously to be improved over time with the lessons learned. To conclude, we can say that the current cold chain recommendation for storage and transport restrict the access to some population. The heat stability data, the technology and the equipment allow for vaccine to be taken out of the traditional cold chain for the last stretch of the journey. It is time to change our practices.
Thank you very much. I think it's important to note that MSF represents a very different kind of user profile from the EPI program, and that emergency response and complex humanitarian settings are contexts with their own unique set of challenges that also could benefit tremendously from the relief, the kind of relief that CTC offers. And so now offering a different profile in terms of user and a perspective from a country setting. Dr. Landoh.
Thank you, Anna-Lea. I think I've said a lot in the morning, and for this afternoon, everything has been said by the other colleague from the panel. What I'm going to say is to try to describe how we come up to the CTC implementation in Togo. In 2013, before the introduction of new vaccines, an evaluation has been done, and it shows that about 35% of the health facilities don't have adequate cold chain, which is problematic when it comes to introduce new vaccine. And the new vaccine have been introduced exactly in August 2014, and we introduced rotavirus vaccine and PCV, pneumococcal vaccines. And in September, November, we were about to introduce to organize the meningitis A campaign. So the challenge was how to store the vaccine and how to transport the vaccine up to the end point of the operational level. And when the opportunities comes to use the CTC, we try to find out districts that have few opportunities or few possibility to store their vaccines at the district level and at the facility level. For example, in one district, Akebo district, we got only one cold chain in the one facility, up to of the 9 health facilities that account for the district, only one health facility got a functional cold chain. So it was an opportunity for that district to experience the CTC implementation. So as Anna-Lea said, the CTC allows vaccines to be stored or to be transported out of the regular temperature, so we can use them up to 40 degrees and during 4 days. So for those health facilities without cold chain, they can keep their vaccine in the vaccine carriers and go to make their outreach activities up to 4 days and come back after 4 days and bring other reapprovisionment and go back to the remote areas to vaccinate people. So I think it's a good opportunity for those districts without cold chain. And the other thing that we try to say, for the scenarios, it's important to define good scenarios and explain to the stakeholders so that they can adequately and properly use those scenarios. For example, scenario 1, it is applicable for health facilities without cold chain, but the district also has low capacity to produce ice packs, because the vaccine comes out of the refrigerator. Once it comes out of the refrigerator, you cannot bring back the vaccine in the refrigerator. So you have to keep them in the cold boxes or vaccine carriers with the PTTI. So for those type of health facilities, they need to be closer to the district and to make sure that they can quickly go to the district and get their vaccine and go back to the field and vaccinate the children. For the scenario 2, at the district level, they have the capacity to produce ice packs so that they can transport the vaccine up to the health facility, and at the health facility, then the CTC can start, so that the capacity of production of ice packs must be good at the district level to help to provide vaccine to the health facilities. The third scenario is the easiest one. At that level, the health facility must have a strong, a functional cold chain to be capable to store their vaccines. And so what? After the implementation of the campaign, we found that it's a good opportunity for Togo to experience the CTC approach, because as I said, we had challenges in terms of cold chain. So one of the panel members said that there are priorities, but also remember that we have to give the chance to all children to have all antigens. And if you look at the evolution of vaccine coverage, the first vaccine that children receive have a good coverage, like BCG, like Penta 0 or VPU 0. But when you go after 6 months, the coverage rates are going down. So I think it's very important to look at those vaccines that are suffering to reach the good coverage, like measles, Penta 3, and yellow fever, to work on those type of antigens and put them in the CTC strategies so that we can help countries to increase their vaccine coverage and give the opportunities to children to get all the antigens that they need to be healthy. The other thing I think I've said in the morning, so thank you again.
Thank you very much. I think Dr. Landoh really touched on some of the practicalities that must be considered when implementing a CTC strategy. And now we're going to continue to get a little bit more insights on some of the issues related to country implementation, especially some of the cost benefits.
Okay, and I'm going to make this very short because I'd like to leave some time for discussion, so I'll sacrifice on my presentation on that. But you know, when you looked at Anna-Lea's graph before CTC really started scaling up, especially after the pilot in Benin, there's a lot of work that was needed to make the case for why do CTC. I mean, I mean, you've heard all the benefits, right? But it's not always easy to convince countries to go ahead and do this. So as part of the work that was done to build the business case around the CTC, one of the questions was, well, are there any economic impacts of this? What you save from doing a CTC? So we started some economic work in Chad back in 2012 in December, where they conducted a Menafrevac campaign, but it wasn't in CTC. At the time, CTC hadn't started. So we actually did the full costing of the campaign and then simulated those 3 scenarios that Dr. Landoh just described to us. What happens if you start CTC at the district level? What happens if you start at the health center level, and so on and so forth. But it was a simulated exercise. We didn't have a case of a country that has done CTC. Although in December of last year, a group of us from PATH and myself, WHO, were in Togo for the campaign that Dr. Landoh just described. And we've collected all of the data to do a full costing in a case where CTC was actually implemented. So we'll have that data hopefully sometime this year. So I'm just going to present really quickly what happened in Chad, and basically it was the CTC scenario 1. can't remember which one it is, but essentially we picked it from, I mean, we simulated all of the scenarios, but it was essentially what happens to the cost of logistics when you start implementing CTC starting at the district level, okay? It means at that moment, vaccines no longer need to be stored in your traditional cold chain, right? And so we had to do a lot of costing and figuring out the bits and pieces that were involved, and some of them actually, even though CTC wouldn't be implemented at a district level, there were some cost impacts at national level, of course, because they needed to prepare ice packs and so on and so forth. So you had different cost savings that might have happened at the national level. Of course, in the case of Chad, their cold chain was so bad they actually had to rent or actually borrow cold chain from other locations to move them to places where they were going to do the campaign to produce ice packs, because they didn't have any ice packs. And these were areas which had no electricity, so they had to rent generators and all sorts of things. So you can imagine the costs and expenses to do this. On top of it, they even had to rent a truck to bring down these refrigerators from different locations to where they were going to be conducting the campaign and so forth. And of course you've got vehicles and transport, and of course you've got the people at the last mile doing service delivery, and they have to walk around with very heavy cold boxes full of ice packs and so on and so forth. So we did the costing of all of these elements that cover national all the way down to the health center level. And so we got the full costing of the campaign, of the Menafrivac campaign, and it was kind of a standard cost, we'd say roughly about 60 cents per person targeted, of which the logistics was actually half of it, okay? So for every person vaccinated for Menafrivac, if you exclude the cost of the vaccine, all of the other costs, half of it was in logistics, all right? This is the guys going around with ice packs, freezing ice packs, running the cold chain, driving the ice packs around, bringing the vaccines, all of these things. There's a whole machinery of logistics that's going on when these campaigns are happening. So what did we find? Well, these are the results right here for strategy 2. You have two graphs, essentially. The one on your, I guess it's on the left, is essentially the cost broken down by component, and then the other chart on the right is the same graph, except you're breaking it down by level of the system, which basically indicates to you where these costs are occurring. So the first bar, the top one, will give you a figure of about 20, let's say 25 cents, just to round it up. Basically 25 cents is the cost of running the campaign with all of the bells and whistles of the logistics that you showed you. When we simulated what those costs would be, by removing certain aspects that don't have to happen in a CTC strategy, you're basically cutting down your logistics cost by half. All right, so there's 50% gain in the economics of doing the campaign in a CTC in terms of the logistics. So that's quite a sizable amount. It might sound little when you're saying it's 12 cents, so you drop it down to 12 cents per targeted person, but when you multiply that up to the target population, you can make some significant savings on the operational costs. The main, you know, not surprising, where the costs got reduced the most were on the cold chain, is basically because you don't need to produce so many ice packs. But of course, on the transport, the cost reduced there because you don't have to run around distributing ice packs. Because when you're in Chad and it's 30 or 40 degrees outside, you need to resupply ice packs several times a day to the same location. You can't just expect that the campaign can be running on the same ice pack throughout the whole day. So it gets complicated. And then, of course, when you start looking at where those costs are at the different levels, you can see that there are some cost savings starting at the national level and all the way down. I'm just going to stop it at that. Actually, that study was published. If you need the reference, we can provide it to you. But just to indicate that we will have a follow-up study, which we're doing, WarePath, in collaboration with WHO, to do this exercise in a real setting in Togo, where we basically have all of those cost indicators, and we'll see how well my simulation matches with the reality. Chances are it won't, but at least the main take-home message is that there are significant cost savings when you implement CTC. So that's on top of all of the benefits that you heard from other speakers. There's also a financial one that's of interest to countries. So leave it at that.
Thank you very much, Patrick. And I realize we started a little bit late, and so we're finishing our panel presentations a bit later than planned, but we really put a lot of value on your input, and so we are willing, I've checked with the whole panel, and we're willing to stay a little bit late so that we can hear what your questions and comments are. So we open the floor now to you. Yes, Dicky. And if you could just mention who your question is addressed to.
Sure, I'm basically going to speak to the procurement and the pharmaceutical industry, I think. I'm Tiki Robenheimer. I'm an expert effective vaccine management consultant, but just for your information, I do have production, pharmacy, and regulatory experience as well. As far as I know, every manufacturer has stability profiles for their products under accelerated and steady states that they build up. I believe also at 43 degrees, so we at least, or it may differ from NRA to NRA. I also believe, and I'm actually interested to see that NRAs, or national regulatory authorities, are now starting to request excursion incidents in stability studies. One question I have for you from the manufacturing point of view, why have they not included more of the EPI supply chain events in their stability studies to get a closer actual simulation of what could happen to the product? I also believe it was as far back as 2001 or 2 that the first publication, or that I knew of, came out on what you were referring to as well, the birth dose hepatitis B being used outside the cold chain in Indonesia. And another point that I put in my logic is that the VVMs are matched with the manufacturer and their stability profiles, more or less, and with due respect, I fully accept your point that it may not be able to indicate, the VVM cannot indicate a 1 or 2 day difference at 42 or 43 degrees. However, if a country has a maximum temperature of 38 degrees, surely that deviation at 43 degrees is not applicable. And the VVM is the first step in getting a connection between stability and practical application. And I just sit here, I'm just asking questions in my mind. I believe here's a huge consumer, customer, patient demand, public health responsibility demand. Why would it be all that difficult, or why has it taken so long to get to the point of having a CTC on label? Is it not time that the consumer and the public health patient puts pressure on the national regulatory authorities? Or is there maybe a point of, when that first publication came out, it cost $1 per fully immunized child, whereas now it's costing more than $10 per fully immunized child. Is that price difference maybe making an impact on resistance to CTC? From the manufacturer's perspective, I don't know. So these are just questions. In my logic, CTC should be standard practice for all those vaccines that can handle, that's got a reasonable stability profile. And it should be made available to the user. But unfortunately, there's this silent void because, and I understand, there's huge public health, legal implications for the manufacturer. But I am not convinced that we can't get to an acceptable solution.
Well, maybe I can try to answer from what I know on hepatitis B. Since, so the whole thing on CTC started with hepatitis B, as you rightfully say. And the first attempt was, WHO was tried to look to which extent the VVMs that were applied to hepatitis B vaccines actually matched the stability. So they put through the stress testing the different vaccines. So they actually found out that one of the vaccines did not match. So one of the vaccines was wrongly VVM'd, basically. They kept all this data confidential, but then they said, well, for the manufacturers that are actually fulfilling the VVM and they're actually correctly licensed, try to make it licensed in CTC. I think with the other company, I actually don't know the company that did not fulfill the VVM. I don't know what the sort of the fate was at the end. So since then, we actually, I think I've convinced just about everybody in my company at the time that this is the right way to go. And we've organized, I think, probably 5 consultations with WHO, in particular for the technical aspects. And we came to the quantity of scenarios that you can have in exposure to different temperatures that are infinite. So we had to take a step back and we said, basically, we need to wait for the regulatory guidelines to what kind of exposures are possible and what is sort of the life cycle of these exposures that we need to test. So the testing that we need to do, and you're right that there is stability tests existing, because to actually apply VVM, you must have some tests in place. You have to prove that you're stable at 25 degrees, at 37, but you need more for this. You need more, and it was very difficult to plot all these scenarios, and I think my colleagues from the regulatory affairs are still evaluating what it would take to make all the tests. So I think that once the guidelines are finalized, we will know exactly what will have to be done, and I think that will be a very good step forward. To be honest, I don't know, for the other companies, they probably had the data existing during the development, because those vaccines that, like Menafrivac, they were developed much later, so the science was already much advanced, and I think that this data was already existing. So for something like hepatitis B, when you have to go back in years, it really is quite difficult to do. And then another thing, if you do any improvements on a very cheap product, you need to make sure that you find the ways to amortize your costs as well. So I think going forward, we'll probably see more of this happening. I don't know if I've answered. Happy to talk to your clients.
And I might also add, so with respect to the regulatory guidelines, this is something that's been under development for the last few years, and we've definitely recognized that it's the lack of understanding or expertise among regulatory authorities on how to evaluate stability data and how to really assess whether a vaccine can be licensed for CTC. That's been something that has been a critical part of the CTC agenda in addressing that weakness. And so it's been ongoing work, and we're actually at the point now where there is a draft set of guidelines that should be made available very soon in the coming weeks, if not maybe days, for public consultation. And so that's something that soon should be available, and it's a major hurdle that I think once we've got those guidelines available for manufacturers and regulatory authorities, I think it's going to really help in boosting momentum and getting more vaccines understood for how they need to be made compatible for CTC in terms of the profile. Richard.
Okay, thank you, Anna-Lea. So maybe my first question will go to you, and then Patrick and maybe Olga as well. I think that the dream of every health workers and public experts is to use vaccine, to take vaccines as other products without the constraint of the cold chain, and then to reach the last mile much more easier than constrained by the cold chain. And I think that when the concept, the process of CTC is being explained in the field, it raised a lot of interest because it's actually, to some extent, bring that enthusiasm of using a product, of course, in a very controlled way, but at least with less constraint of the cold chain. But however, when we look at the, and again, 2 or 3 years down the line of the experience we've accumulated in, compiling data on CTC, and I think now more than 2 million doses being administered. Don't you think that we are too conservative with the rules that has been put in place to use CTC? Number one, it has to be in a campaign, it has to be in A, B, C, D, etc. So, and that actually is preventing the, and tomorrow we are going to use Men A in routine immunization. So the same vaccine will be, say, well, you can use it in CTC mode in campaign, but you can't do that in routine. Do you anticipate that with the data that is going to be accumulated throughout the, let's say, the next couple of years, are we going to see a scenario where we are going to see like what has happened for Rota, with loosening some of the condition in using that? Otherwise, it will have very little interest, because in West Africa or in the meningitis belt, very soon we are going to be done with the campaign. So is that CTC going to be died? So then PCV has been registered, but we know very well that in the majority of the case, PCV is used in routine. So what is the interest of that? So I would be interested to hear a bit on that. The second point was on the economics, Patrick, that you presented. I think these are very interesting data, and I don't know if you've already preliminary data of the Togo campaign. Is it confirming the simulation that you've, with the result that you have just presented? And I want to link that with the presentation that Olga, you made, and I was not familiar with that study from the foundation, that only less than 1% benefit for CTC. That's very disturbing. So why are we doing that to gain less than 1%? It doesn't make sense economically. So how these data, and again, I've not yet seen that report, are in line with what Patrick has just presented, that we see that almost 50% gains in CCL logistics has been gained with the use of CTC. Thank you.
Okay, maybe I'll start and then I'll let you answer the second question. So first of all, I think when discussing the rules around CTC, what I want to maybe clarify is that it's true that our current strategy is to prioritize vaccines for campaign and special strategy settings. And this is not to say that we wouldn't like down the road for CTC to be applied to a routine setting. The reason that right now we are not encouraging routine vaccines as much as we are vaccines that are used in campaign settings is because basically with CTC, first of all, you know, this is a new innovation, a new strategy that we want to be sure of success, and it's really all about sort of a risk-benefit analysis, and we want to make sure that the benefits brought about from CTC are greater than the risks. And in the case of a routine setting, because when we're talking about routine, we're talking about really a package of vaccines, and so to administer some in a CTC and others where you have to maintain the cold chain, I think there's a significant risk of undermining the good practices that we've worked so hard to ingrain in health workers. And so I think there's a risk of confusion, and it undermines the benefits that CTC can offer. And so when it's given in a campaign setting, we can isolate, it's a vaccine that's being given on its own, while in a routine setting, typically its vaccines are together with others. And so You mentioned PCV, and that's exactly, in fact, one of our issues with PCV13. It was not part of our priority vaccine list for CTC, and the reason being is because it's typically administered in a routine setting together with Penta and polio, which require cold chain, and so there's minimal utility to having the CTC option for PCV13 when it needs to be given together with vaccines that need to rely on the cold chain. And so there's more risk of confusion and ultimately vaccine being administered that perhaps has been exposed to temperatures that render it not potent. And so for the time being, until we have more vaccines that together can be offered in a routine setting, I think it's better to concentrate on campaign and special strategies. And in the case of PCV13, I think right now, as I mentioned, we, in a routine setting, we would not encourage the application of CTC, but there is still scenarios where there is utility, and that's especially the way MSF uses PCV13, and so that's the reason why we still have the intention to provide, to develop guidance on how PCV13 could be used in a CTC, and that's guidance that we would develop together with MSF, and so it would be probably more useful to MSF or those kind of settings that they operate in, where we would be endorsing its use, but we probably would not be encouraging it in an EPI setting. Patrick, do you want to take the second question?
Yeah, thanks for your question, Richard. Actually, you know, there's been a bit of delay in this Togo study. I've been having to organize this small meeting that's been taking a lot of my time. Just kidding, but we're doing this with PATH, and we're still going through the data. So I can't confirm the information, but I will say this is, I mean, I didn't present the ranges around these costs because we did have ranges. What I presented was the average. My gut feeling is that, you know, even though in Chad we simulated maybe 50% reduction in the cost of logistics, I think that's on the high end. Because in Chad, I mean, it was a particular case, and the setup for the campaign was, I think, not something that's generalizable for a lot of countries. I mean, there was a lot of expenditures on things that most countries wouldn't have to do. If you have a country that has a very strong health system with good cold chain and so on, those savings might start dropping a bit. In Chad, I mean, there was just basically nothing, so you had to bring things there. So of course, when you don't have to do that, then the savings are much higher. So I think that might be overshooting the benefits a bit. I'll be honest about that, but I expect we'll see benefits anyways. To what level of magnitude we'll find in Togo, that's still an open question.
I wanted to follow on to that a little bit. It was interesting results from the economic analysis. We've done some Hermes modeling around removing different vaccines theoretically from the cold chain and looking at the economics of that in a routine setting.
Usually you don't need a mic for a reason. I can't hear you.
So we've done some Hermes modeling centered around removing vaccines from the cold chain and simulating them in a theoretical sense as if they were put into the CTC and looking at the benefits in a routine setting. And one of the key factors there is that you have to remove enough vaccine to remove the cold chain requirement. Because if you're not removing all the vaccines, then you still have to maintain cold storage and incur recurring costs for the cold storage in, say, the health centers and such, and that reduces that effect, the cost savings you get from it. But if you can remove enough, I mean, removing one doesn't really have much of an effect, but removing 2 or 3 or targeting some of the big ones, the more spacious ones, have a big effect. I just wanted to mention that and compliment your study.
That's interesting. Thanks, Sean. And you know, I think we're going to also have some settings, and I think we'll see this probably in Togo, where the transport is actually where you're going to get the biggest impact. I mean, I was based in one of the areas doing CTC, where there's absolutely no electricity. Yet it's right on the border with Ghana, and you can just walk across and get yourself a really nice cold beer. But on the other side of the border, there is absolutely no electricity. And the only place to go resupply for ice packs, if you wanted to go for ice packs for like a traditional cold chain, is a 3-hour drive, right, on really bad roads. And so if somebody has to do that 3 times a day to resupply ice packs because it's baking hot out there, I think on the transport side, you're going to have a huge impact. So even if you need to have enough vaccines to maybe remove a piece of cold chain equipment, you also have that effect on the transport side, which might make it beneficial either way.
Also, on that point, I think we can reduce also the utilization of cold chain. We can put 3 or 4 health facilities or health centers in we call it in French, réseau. So they can use one cold chain, and each health facility will come and take their vaccine at the same point and go back to the activities or outreach activities. Yeah.
Right, so it's basically one health center becomes a hub for many, and that also helps consolidate things and save.
Yeah, the analysis that we published, we didn't consider redesigning the system around it. We were just trying to look at the effect of removing. So it would be interesting to explore those that.
Okay, we'll take just 2 more questions. So we'll start with Nasrin and then Amadou.
Okay. Thank you for all the presenters. My question is just to be, there is still some issues in this CTC is not clear for me. First, before the license for MenA, how many countries tested this strategy? And during the testing, did you test the potency of the vaccine? Because you said the main issue that the safety and stability. But what about the potency, i.e. the immunogenicity of the vaccine? Did you test the immunogenicity of the vaccine when you applied as a CTC? This is one. The other issue for MenA, it's 40 degrees till 4 days. And during campaign, did you test in countries that have more than 40 degrees? Are they stable for MenA? The other issue about you said it's limited to the SIAs or campaigns, not during the routine. But I couldn't understood. PCV13 is also licensed to be CTC in a routine setting, not in the campaign, because PCV is not a campaign, it's a routine. Why not meningitis A also used during routine? For countries that finish from the campaign and now they will introduce it into the routine system. The other issues about during for the presentation from Togo, they said they have 3 scenarios. One of them that in areas they apply the CTC, in one area not applying the CTC. In those areas that apply CTC, did they discuss with the community before applying this strategy and they take their consent? And what about the ethical issues here in this point? Because if we want to replicate this because in our region, EMRO, we have still one country to continue the MenA campaign, which is North Sudan. So I just want to be clear in these issues before advocating for this. Thank you.
Okay, well, I can start to answer that, and then I welcome any members of the panel to chime in if they want to. So first of all, to clarify, so when we get to the point of licensure, in the case of Menafravac, so when we're talking about CTC, we're not talking about a reformulation. It's the same formula. It's just that the manufacturer was able to demonstrate that the vaccine had a certain stability profile that allowed it to tolerate where the vaccine remained stable. And so that's why we did not, once it was evaluated by regulatory authority. In the case of Manafravac, it was the DCGI of India. We didn't have to look at potency. Once the regulatory authority has approved it, it's determined. It looked at the stability profile and determined that it did not change when exposed to higher temperatures. And so when it was licensed, it was only after licensure that we did a pilot program where we got involved and decided to do a field test. And at that point, so they weren't looking at potency, but they did look closely at adverse events, and that's continued to be something that we pay special attention to, and that was the case again when we implemented CTC with Manafravac in Togo and Mauritania and in Côte d'Ivoire in 2014, and what the results showed was that there was not any difference in terms of the rate of adverse events between districts where CTC was implemented and those where CTC was not implemented. And so I think certainly from a safety point of view, we continue to collect data that demonstrates that CTC does not create an impact in terms of safety or undermining it. And as far as your question related to routine, so as I was explaining in response to Richard's question earlier, again, right now our priority is not to undermine the routine program in any kind of way, and not to undermine cold chain practices, and so that's one of the reasons why we want to focus on a campaign or special strategy setting, because as soon as we're talking about routine, we're talking about other vaccines that could possibly get confused, and so it's only when a vaccine is administered in isolation through a specific strategy or campaign that we encourage the use of CTC, and it's all about being sure that adoption of this strategy can bring real benefits. And that's why even in a given campaign, for example, in Togo, as you might have heard in the presentation this morning, the campaign was conducted in a much larger setting than where CTC districts were. So CTC districts were selected just on the basis of the need, where we recognize that there would be a legitimate advantage brought along by the CTC strategy. And so the districts were very carefully selected on the basis of cold chain constraints, of access issues, and where we realized that the benefits brought along from CTC would outweigh any possible risk in terms of confusion with cold chain, and so that's the reason why it's very carefully selected. And in routine, you can't apply the same kind of strategy where you're singling out specific places that would benefit. But it's again a question of the fact that it's in routine, vaccines are bundled together. While in a special strategy or in a campaign, you have a single vaccine that's been administered. And as far as the three scenarios go, so it's something, it's a decision that's made part of a strategy that. Yes, so in the case of PCV13, though, it's not going to be part of routine and part of the EPI program. If it's administered, it's going to be administered again through a special strategy through MSF, where they PCV13, but in a humanitarian complex emergency setting, so not standard routine immunization.
No.
No, absolutely not. We're not. Yeah. And I think that's a very valid comment. And I think really at the point where we're at with CTC and vaccines, really we have to sort of see what is the trend, what are the kind of vaccines that are getting license, and take it product by product and determine what's the appropriate strategy to build around a given vaccine. And so right now we have Manafravac on the market, and now suddenly as of May 1st we have the option with PCV13, and it's about handling each product and recognizing, okay, what kind of flexibility is it offering us, and what's the right strategy to build around that particular vaccine. And so, I mean, I take your comment very seriously, that of course we don't want to close the door on the possibility of using it in a routine setting, but for the time being, so far, it all comes back to this risk-benefit analysis, and we have to always strike that balance in terms of making sure that when we do CTC, we're guaranteed of success and guaranteed of really bringing a valuable advantage to the program and not undermining any established aspects of the program. Right now, what we've for Menafrivac and as it turns out for PCV, the peak threshold that it got licensed for was 40 degrees. Yes. So I'm gonna do one last question from you, and I'm afraid then we have to stop.
Yes, thank you, Anna-Lea. I think my question is for WHO in its regulatory, how to say, casket. We have the mRNA vaccine that has been PQS for 4 days. And now we have the PCV13 that is coming for 3 days at 40 degrees. I think it will be worthwhile for WHO to set clear guidelines for at least manufacturers that Olga is representing here. Because the programmatic aspect, as Richard and I think it's Nasrin, when this becomes routine. For a health agent, yes, this vaccine is 4 days, but this next one is 3 days, so we'll have 5 days. I think it will be very important for WHO to tell to manufacturers 4 days, 28 days for the hepatitis B0 when it comes out, and then maybe 3 months, and stick to those, because I'm pretty sure that PCV13 is going for 3 days. This is to be on the safer side. I'm pretty sure if there were clear guidelines that at least 4 days will not accept it, the manufacturer will come with 4 days. I think we need to align so that when this becomes routine, it will become easier for the health agent who is far away from everywhere. And if he has to do this, yes, this is 4 days, but 3 days, 2 days, then 10 days, it becomes very difficult. And we will need to send a clear signal at least to our manufacturers that we have 4 days, 28 days, or maybe 3 months, whatever, but at least clear guidelines in order to harmonize so that the programmatic element of this can be easier for the health agent. Thank you.
Thank you. That's a very important point, and I appreciate the point you're making. I think you know, it was a bit of a struggle for us to determine, you know, what was the minimum acceptable, and we had to strike a balance between what has programmatic value and also what would limit manufacturers from being able to make something compatible with CTC. And so the way we came up with the 3-day minimum was basically, we thought, okay, from a programmatic point of view, really to have utility, a CTC context really needs to be at least, allow for at least 3 days out of the cold chain. The reason that we don't limit it and require just 3 days is because it really depends from product to product. That can vary, you know, in a scenario such as the oral cholera vaccine, where you have a vaccine, it's 2 doses that are administered 2 weeks apart, there wouldn't be much use in just having that in 3 days. And so there's the issue of the fact that, you know, from product to product, there's different advantages in terms of the duration of the temperature excursion. There's the fact that we don't want to limit a vaccine's capacity or potential to be made compatible with CTC, so that we have more vaccines that come on the market that can be used outside of the cold chain. And yet at the same time, we want something that has programmatic utility. And so we had to draw the line somewhere. And there's arguments for longer, arguments for less. And finally, we had to come up with a balance between those different benefits and disadvantages. And we came up with 3 days. And we recognize that there's a potential for confusion, but it's a risk we had to take. So I want to thank you very much.
One more question, please.
Okay. So please, if it can just be very brief, because we're already a half hour over time, yes, and everyone's been ever so patient.
Sorry, I mean, this is a very interesting topic. This is why so many questions. Actually, I like idea of, you know, the getting rid of the cold chain, and but we also have in many technical forums, in TechNet also conferences, discussion was about integration. integration of the API cold chain, API products supply, and also other medicine supplies. So how this strategy is now in line with the integration of the supply chain is number one. Number two, actually, there are many products now on PQS catalog. Cold boxes, vaccine carriers, which have very long cold life. 1 week, 2 weeks, even some products can go up to 1 month on one ice pack charge. So does it possible also to take it into consideration in developing a strategy for this campaign? Shall I repeat my questions?
Sorry, yeah, if you could repeat. I don't know if someone else understood. I didn't fully understand your question. Your second question?
First question is about integration. We are talking about integration of API supply chain and other medicine supply chain. How this strategy is related, interlinked to the integration. And second question was, we have now in PQS products, cold boxes, vaccine carriers, which on one charge of ice packs can go 1 week, 2 weeks, some products even 1 month. Can this also new products take into consideration for developing campaign strategies? Thank you.
Patrick, did you want to?
Sure. Thanks, Nordin. I mean, I don't personally see any conflict between a CTC approach and supply chain integration. I mean, supply chain integration, you can bring vaccines, whether they're CTC or not, into other health commodity supply chains. I'm not quite sure why that would be in conflict. You're just putting the products together, and it would only be relevant for countries that move in that direction. So I'm not sure where the tension might be there. On your other question, I think there could potentially be a tension if more and more vaccines start getting licensed to be CTC. So we're going towards CTC when the cold chain equipment companies are moving to long-term passive cooling systems with cold packs and ice packs that can last very long, which means you can actually take the cold chain further down the system, whereas one way is telling you you don't need the cold chain anymore, and the other is telling you now you can take it as far down. So they could start getting a situation where we might be sending mixed signals to our friends who are in the next room, right? Because they're designing and developing equipments in a certain way. So that I think we're still early days. I mean, there's only two now, vaccines and CTC. We're still kind of. I don't think we've gotten to the point where it's going to be a problem, but it's certainly something we'll need to look out for when, this is the topic here. Where do we go from here? And I think one of the things is to make sure that we start aligning the strategy. If it does start moving to something more routine, then I think we will have to seriously consider all these questions. At the moment, if it remains as a campaign setting, I don't quite see that your question on integration or how it might impact manufacturers and where they're moving with their equipments. I don't think that tension is going to happen. But who knows? Maybe in 2 years at the next TechNet, we'll have a big session on CTC and all of the problems it's causing. Just kidding.
Thank you. Yeah, thank you very much. That's the perfect way, I think, to close. And if I might just add, if you want to continue discussing about CTC, you do have one more opportunity tomorrow, because we have down in the poster and video gallery, there's first of all a poster, it's our infographic about CTC, but also we have a brand new 3-episode film all about the different issues surrounding CTC, and that can be viewed down in the video gallery. And tomorrow at 1:15 I will be available to continue discussing about CTC. I'll be there to answer any questions that people might have with respect to the contents of those videos, but of course, welcome any discussion surrounding the topic of CTC, and I'll be available at 1:15 down in the video gallery tomorrow. And so I invite you to come and watch the film and to discuss further this important topic. So thank you so much for bearing with us and for sticking around until 5:30. I appreciate your interest, and I hope that this dialogue can continue, and your inputs were really very helpful. So thank you so much.